Okay, let's go on and get started. I do want to introduce myself. I'm Jeff Harrison. I teach at the University of North Florida in Jacksonville, Florida. And I have no financial interest in this presentation. And I would encourage you as we're going along, if you do have questions, feel free to put your hands up. We can address some questions as we're moving forward on the presentations. I do recognize a few faces here. I presented earlier this week on Wednesday. And hopefully I think you'll enjoy the presentation today. We're going to talk about a simple tool for measuring performance outcomes. My co-presenter, Nick Coppola, could not be here. Nick's a great guy. He's a good friend of mine, a colleague. I was a Navy healthcare administrator, and the Navy was very good to me in my active duty career. The Navy paid for my master's degree in health administration early on. And then later in my career, they sent me back for a PhD in healthcare research at Virginia Commonwealth University in Richmond. And I got a chance to know Nick Coppola there during the PhD program. He's a little younger than I am, probably better looking if you look at the picture, but he couldn't be here today, so I'm going to kind of carry the ball. Now, I'm actually chair of the Department of Public Health at the University of North Florida. As such, I'm responsible for our health administration programs, both undergraduate MHA as well as our public health programs, undergraduate MPH, as well as the mental health counseling program, our graduate program, as well as geriatric management. Nick and I have published quite a bit dealing with federal health care issues. We've done some joint research as well, and we'll share a little bit of that information as we move forward. I told you I came from Florida, didn't I? This is an actual, true picture. Not this year, thank the Lord. But it's an actual, true picture. I started out every once in a while, particularly when I come to different geographic areas. It was a hurricane over Florida. And literally, I was right in the middle of it when it came through. But I start this presentation with this picture for a couple of reasons, one of which, in my mind, healthcare is a lot like a hurricane. It has a direction, and you can see the direction that this hurricane goes as far as the way it rotates. It has a velocity. Did anybody hear about the hurricane that, well, we call it a hurricane where I came from, that just hit Manila? It was over 200 miles an hour. Category 5 is 150. We have buildings in Jacksonville, Florida that can withstand Category 5 hurricanes. I cannot imagine 200 miles an hour. I've been in hurricanes that are 130 miles an hour, and you don't want to be there. 200, and I've also been to Manila, and I don't know how those buildings can withstand 200 mile an hour winds. So I sympathize for them as well. But like a hurricane, we don't exactly know where healthcare is going. Okay, it's got a direction that it rotates. It has a velocity, but we don't actually know. And even though we have Obamacare, they're still fighting about that. So that's kind of my allusion or allegory to a hurricane in healthcare. Does anybody see this picture on the news? Anybody see that picture? The Asiana plane crash in San Francisco took place on July 6, 2013. The good news is, does anybody remember how many people were killed on this plane crash? Anybody know? Well, actually, none. I heard somebody say none. And that's actually the correct answer. One passenger did die. You know how that passenger died? Got run over by an emergency vehicle when they sprayed the plane down with foam. They didn't see the patient under the phone, and they drove an emergency vehicle over him. I think that's what happened. But I think this picture is slightly relevant to what we're going to talk about today. And I want to share some thoughts from a leadership colleague of mine. His name is Bob Wolson. And he was watching out of his back patio, which looks out over the San Francisco Bay, and he saw the fire burning on the runway at San Francisco Airport. And he wrote this: I've been musing about what the leadership lessons we can learn from this tragedy. And here's what I've learned. Based on the information I had, and it was within a week after the plane crash, there was a team of 3 experienced pilots in the cockpit at the time of the crash. The pilot flying the plane had little experience flying the Boeing 777. He had never landed a 777 at San Francisco Airport. He was the student pilot on this team. His instructor, the co-pilot, had more experience flying the 777, but this flight was his first as an instructor. The third pilot piloting the cockpit sat in the jump seat. There was a fourth pilot in the passenger cabin at the time of the crash. The instructor pilot testified that he assumed the automatic throttles were maintaining the plane's speed at the proper level. The day was very clear. The wind was gusty, but that's typical of San Francisco. It's nothing new in San Francisco. And the 777 has an extremely high safety record. The fact is that a safe, sturdy plane crashed with 4 experienced pilots on board on a clear day. Why did it happen? How could it have happened? Here is my hunch. Although the pilots were all very experienced aviators, each had only a little experience flying the 777. The pilot team, remember the word team, was working as a team for the first time in these roles and with this airplane. So here's some questions I have unanswered in my mind. Did the team organize effectively? Did they delineate clear roles and responsibility? Did they have a working relationship? Did they have a communication plan within their group? Was there a feedback plan? Was there a decision-making plan? Was there a clearly designated leader of the team? Did the team members know each other's way of communication and feedback within the group? So what are the takeaways for us as leaders, and we're healthcare leaders? Well, just because team members are experienced does not mean the team will automatically succeed. How true is that? The team organization is essential to a team's ability to successfully achieve its goal. There needs to be somebody leading the team. They need to set expectations. They need to hold members accountable. They need to keep their eye on the goal. And they need to monitor and evaluate the data in comparison to performance. All team members must look out for each other. They have to communicate. They have to challenge. They have to collaborate. And they need to prevent mistakes and failures. This airplane, and I went out on the internet and got the data. This airplane will hold between 400 and 440 passengers on the plane. The good news is only one died. And the reality is only that one didn't die in the plane crash. They died a little bit later, as you met. So what are some takeaways for healthcare? How does communication break down? Well, it can break down with unclear orders, poor handoffs of information within the team, interruptions, not speaking up when you're concerned. When you see something that bothers you and you don't speak up, that's not good. Not listening to others when they're concerned, and not calling for help when you need it. So some lessons from the airlines, and we've got Air Force people in here, and I'll also tell you, I spent enough time in the Navy, 23 years, to know when we had mistakes, we had safety stand-downs. And everybody went to school on the issues and what the concerns were, and we made sure that we figured it out and we institutionalized the process, and that's all good. And luckily we're in a situation in the military we can do that. All right, some takeaways. The importance of the teamwork, mentoring people within your team, using automatic flight controls. Have we got automatic flight controls in our hospitals? Sure we do. Electronic medical records, warning things. We've got the medical record or the your medication alerts, all those kinds of things. You got to train in simulators. We're seeing more and more simulators in our healthcare institutions. We're certainly using them. I teach at a university. We've got simulation centers where we're giving everybody check rides, and we practice the emergencies. That's the good news. Crossing the quality chasm. Institute of Medicine 2000 report. In that report, the Institute of Medicine reviewed the data nationwide and believed that we had in excess of 90,000 people that we killed in our hospitals each year. Okay? Now, the AMA wouldn't believe that. They said, there's no way. These are people that were in our hospitals but died for a different reason based on something that we did. So the Institute of Medicine in 2000 gave the AMA those 90,000 medical records. The AMA then went through those medical records, and they agreed that 44,000 people died in U.S. hospitals in the year 2000 because of a mistake or something that we did in our facilities. Now, I'm pretty good in math. I'm a healthcare researcher. You take 400 people on a 777 airplane that we just looked at in San Francisco. You divide that into 44,000, and I wrote the number down. We're crashing 110 Boeing 777s in our hospitals every year. At least we were in 2000. Now, we've had a lot of improvements, but I highlight that because the way we make decisions, the processes that we use, the involvement of teams, communication, all those kinds of things can have a very, very positive impact. And here's the short of what they said on their study. Quality problems occur typically not because of a failure of goodwill. We want to do right. Everybody in healthcare, we're in healthcare because we care about patients and we want to do it right. It's not because of a failure of goodwill or knowledge, and in many cases resources, but because the way the healthcare system is organized. Fragmented, not integrated. Now the good news is within the military and federal healthcare, within the VA, we are integrating that care at the clinic levels, the hospital levels, the post-acute care levels, even home care. Trying harder will not work. We got to change the system to make it do it. And the good news is we've done a lot of that within the federal healthcare. All right. So, what are we going to talk about today? Well, healthcare leaders have a significant difficulty in measuring outcomes, in looking at them empirically, statistically. There's no single model that works best all of the time. We're going to talk about a simple model that you can use that'll provide you a framework that you can use in any healthcare institution as you move forward. And a lot of it deals with team building and tracking information and communication. All right, the takeaway. After this session, participants will be able to more effectively communicate and model key issues in the healthcare industry. They'll be able to more effectively communicate objectives, measures, and you'll be able to benchmark. What are the key factors we need to look at? What might have saved that airplane from crashing, okay? Certainly if they had been using the automated quality control tools that were on that airplane effectively, it probably wouldn't have dropped below its landing speed, and it might have saved at least one person. Objectives. We'll talk about a brief, understandable healthcare model that can improve organizational performance, and we'll come up with some ways of measuring it, and those ways can be used in multiple settings across the healthcare institution. Okay, I got a pre-test for you guys, and we're going to talk about a decision-making process. There's one person in this room I know for sure recognizes this picture. Anybody recognize that picture? Okay, what is that picture? It is, I knew it as a Navy officer, and it was called Bethesda Naval Office. Bethesda Naval Hospital at the time. Let me tell you about this hospital. The original hospital, it was the tall tower on the left-hand side. Have you ever been in that facility? Have you? So you've ridden the elevators in that thing, right? Is it 27 stories high? Does that sound about right? About 27 stories high. It was originally built to have 1,000 hospital beds in it, 27 stories high. I've ridden those same elevators. I never had to take care of patients in that building, but I can tell you from when I rode the elevators that a staff member or a patient, and the ORs were on one floor, the wards were on the other floors. You spent your entire life in the elevator in that building, didn't you? Okay? Let me tell you where that building came from. Franklin Delano Roosevelt in 1938 went to North Dakota, and he went to a brand new state capitol building built in North Dakota, and he liked the building. And at lunch, he took his napkin. I don't have a napkin up here. And he drew a picture of that building on that napkin. And he brought it back to the federal construction engineer in Washington, D.C., and said, the next building we build in Washington, D.C. has to look like this. Guess what building came up in 1938? That building. And it was built as a hospital. Nobody in healthcare, and I don't care if you're a doctor, a nurse, an administrator, or a patient, would have ever built a healthcare facility that's 27 stories high. Okay? Did we crash an airplane when we built that hospital in 1938? There's no question. And if you had just had the team discuss it prior to building it, maybe they would have let somebody else take that first building. How long do we, the Navy, deal with that building, that tower, 27 stories high? Until 1975, when they built the building components on the right-hand side, okay? The building components on the right-hand side, it's got 500 beds in it. It's 7 stories high. One of my children was born in that new facility on the right-hand side, okay? Much better designed for healthcare. So we survived within that old building for all those years. It turned over to the Army, as you know, or actually became a joint service facility, and that's okay too. It became called Walter Reed National Military Medical Center in 2011, and Lord knows what it'll be in 2013, but there's a planning process, and everybody needs to talk up and be involved in the planning process. Now, let me throw out one other question, and I don't know I think I know the answer to this question. Does anybody know where the president stays when the president is admitted to Bethesda Naval Hospital? I see if somebody pointing. Which building do they stay? I am told that there is still a penthouse on the very top of that 27-story building, okay? And because of security issues and things like that, it's easy to cordon off. I am told, but I don't know for a fact, that when the president is seen and admitted, he would be in that tower.
That's not exactly correct. I was the deputy commander of Bethesda. But it's that building, it's just as secure.
Okay.
It's that building just to the right of the tower. And it's an entire wing that's secure.
Is that right? Okay.
It's got bulletproof glass.
I can tell you, well, see, and that's why we all learn something new every day. But it is, great facility. And I'm sure it'll continue to be a great facility. But certainly that is a case study of how you make decisions. And I got to tell you, they're recording this presentation, so I'll try to stay out of any political stuff. Moving on. I threw this slide in for 2 reasons. The first reason is everything an organization does has to be based on its mission, vision, and values, okay? So the people that are in your organizations, part of the reason they're in your organizations is they believe in the mission, vision, and values of what we're doing in DOD and in federal health care. Now, so that's one of the reasons I put that slide up. Another reason is setting an example is not the main means of influencing others. It's really the only means. Albert Einstein. We as leaders set examples every day, and we have to walk the talk. And when we say the team process is the way to go for decision making and getting people involved, we got to walk the talk as we move forward. Also, I put it in there because this was chapter 2 of a textbook that I wrote, and that is used in health administration. It was published by Health Administration Press. It deals with strategic planning on how do we get organizations to move in the right direction and do the right things. Okay, some interesting things here about leadership, and I'll just throw them up. We'll talk about them briefly, and then we'll move on. We already talked about, from a leadership perspective, we got a model. We set the example. We set the example for the individuals and the organizations as they move forward. And we have to inspire people. We have to have a shared vision, and it's part of the reason I used the previous slide. There's a vision, and we have to inspire people, and I think the military and the VA does a good job of that. We have to challenge the process. I've been in the federal government. I know how difficult it is when somebody comes to you and says, "We will build you a new hospital." 1938. I don't know what it looked like before. And somebody probably says, "Great. We need the new hospital." We certainly needed it in 75 later. But when you look at the plans, you just got to say, that would be great for somebody else, but it doesn't work in healthcare because we're moving patients up and down and all around, and this just doesn't facilitate moving it. So challenge the process, speak up, enable others to act, and encourage the heart. And we in the military, more so than civilian healthcare, in the military, we know that if we're going to be successful, leadership's a tough thing. And when you turn around and look behind you, and you're out in front of the team, and there's nobody behind you, okay, that's a very lonely place to be. Civilian healthcare doesn't, I don't think, appreciate it as much as we do in the military, because if you don't have your team behind you in a wartime environment, you got a big problem. You're out by yourself. All right, so the leadership challenge. Interpersonal communications, very, very difficult. Very, very difficult thing to deal with. You're communicating, you have a receiver, and you're trying to get your message out. And you want to get your message out with quality, with accuracy, and clarity. But you have some confounding, or what Nick called perceptual screens, that break that down. Being age, gender, values, beliefs, culture, experiences, needs. I spend a lot of time teaching young, not so much undergraduate students, but master students. How do master students today think you should be communicating? How do they think? How do they communicate today? The internet, man. If you're not emailing it, I have been in homes with friends, and the kids would be upstairs, the parents would be downstairs, it's time for dinner. Do they call those kids down for dinner? No. The parents are sitting downstairs on the internet, one computer, they email the kids, say, "Come on downstairs for dinner." Okay? Even in their own houses. Now, I'll also share with you, in our master's program, I don't get to teach much, but I teach the last course, we call it the capstone course, in the undergraduate program in health administration, and the last course in the MHA program. My MHA students in Jacksonville, Florida, in their last academic course prior to going out in their residencies, go in and do an entire business plan on a new business initiative at either one of the Baptist hospitals or one of the Ascension hospitals, we call them St. Vincent's in Jacksonville, or at Mayo Clinic, or at Brooks Rehab Hospital. They do an entire business plan. They then write the business plan, they do a PowerPoint of that business plan, and they present it to senior leadership. in those organizations. And we've done projects dealing with doubling the size of emergency rooms, the whole bottom game, the whole ball game. And the first thing I tell them, you have to sit together and plan this stuff out together. Okay? You can't do it via email, internet, assign work, and that kind of stuff. Because you have to see the commitment. You have to get input from people. You need everybody's input. And I send them out in teams of 4 to 5. One person with clinical experience. We got a lot of physicians in our classes. We have a lot of nurses in our MHA programs, physical therapists. I put a clinician on the team. I put an administrator on the team. I put somebody with a good finance background on the team, and then somebody else. And they go out and they do a good job on these projects. Every team I have had fail, and I have had teams fail, they tried to do this stuff via email. And I said, how many times did you, over a 10-week period, did you sit down in groups and work on these projects and work on how you're going to do it and assign the work? Well, maybe 2-3 times, and then they're in trouble, okay? Young people today think, they don't understand the importance of communicating one-on-one and getting information back and forth. All right, moving along. Communication is the process of transmitting one message to receivers. There's different types of communication that are appropriate. What's the optimal way? You have to make the decision on what's the optimal way. Mom, I caught a huge fish, but it's a little one. But somebody else is sitting on the boat. Mom, I caught a huge fish, and they pulled out a whale, okay? And everything is in perspective, and perspectives change. So just keep in mind, I like this question. This is Nick's slide. What does secure mean when you're talking about the Joint Commission and you're securing a medical record? Do you secure it in the trunk of your car and then lock it in the garage? I got a story to tell you about that, but it won't be. But I won't tell it today. In the pharmacy where we have 24 7-hour supervision by various employees, is that secure? With an armed security guard at the information desk who looks like Dirty Harry. That's a cute one. In an encrypted file on the physician's personal home computer. What is the answer? And we'll talk about what the answer is in a minute. But all of them are varying different opinions. So understand your environment. How far is far apart? Well, if you're a physicist, it's just the difference between one electron and one neutron, okay? But if you're an astronomer, it's in light years. It's all relative, and you have to understand the environment. How long ago is long? Paleontologists, they're looking at millions of years. Jurassic Park, okay? But if you're a kid, it's to their next birthday, or it's to Christmas now, right? Everything is relative based on the individuals and what you're looking at. And then you throw in healthcare. And healthcare, believe me, from my perspective, healthcare, and it's supported in the research, healthcare is the most complex industry, okay? Bar none, okay? Bank of America, they do a great job processing 2 million checks a day, okay? But the reality is Bank of America is processing one check 2 million times. If you think about it, it's all electronic, it's all digitalized. They scan the numbers on the magnetic numbers in the bottom of a check. But we're seeing, and I showed the numbers in the military healthcare system, we're seeing hundreds of thousands of patients a week. And we can't, and they're all individuals, they all are different, and we have to create an environment that does that. All right, so healthcare is very complicated. Everybody will agree with that. And it's further complicated by age, gender, occupations, and the experience of the people that are in those environments. So we got a complex system. So what do? Well, you got to know the audience. You got to know the parlance of the profession. In this room, we can talk about different terms, and most of the people understand them in this room. You get outside of this environment, particularly to patients and family members, they don't understand. They don't understand the parlance. Maintain competency, so that's some of the things we can do. All right, getting back to a secure medical record. When we talk about secure medical records, a few of the kinds of things that we should be thinking about in our business. Key control. You put in place key control over those. You put in place restricted access. So only people with a need to know are allowed to go into that medical record, and you audit that medical record, and when you find people in it that had no business being in it, well, then you deal with that, and that's a serious issue. Authorized people, history of documentation, you have written policies, written procedures. So from a perspective of how do we secure records, these are the kinds of talks that we should be having. And we do have. We do have. All right. Leadership competence. We got cultural differences between surgeons and nurses, between technicians, between administrators. A lot of those lines are being, they're becoming blurred over time. Keep in mind, every stakeholder is unique. They all have cultural issues to deal with, but it's critical to build solid, positive relationships across the culture, and to facilitate the movement of information across that culture. Develop mindfulness. Be conscious of cultural differences. Be flexible. Be willing to adapt to change. Don't hold on to stereotypes about certain groups or certain issues, and ask questions. Part of the reason to be asking the question is, where's the president taken care of? I don't know anymore. I could not imagine him on the 27th floor, so your response is certainly a very good answer. Looking at terms. What do terms mean? Well, big. I'm a big guy, okay? I'm a big guy and getting bigger, and that's probably not good. But when we talk about blood pressure, we talk about high. But how high is too high? Well, we've got some pretty good metrics for that. And we'll talk about those in a few minutes. Large. What's large? Well, I'm a big guy. Maybe they could call me large. But large is an important measurement when you're talking about the size of a tumor. So these kinds of communication issues are important. You got to understand, you've got to, Nick puts in here, have a good ethical foundation, a good moral foundation. It's a process of sending information, receiving information, and there's actually a theory on the movement of information. And it's called the media richness theory, which is kind of cool. And richness refers to the ability for instantaneous feedback, for verbal, nonverbal feedback. Coming back to my students again, where they think the email is communicating, and it's really not. Okay, face-to-face communication is important. Focus on groups, large groups, and an email is important to communicate with people over wide distances and that kind of stuff. All right, here's a nice continuum, and we'll talk about it and you've got the PowerPoint presentations, so you can go back, you can think about this, you can talk about it on your own. The left-hand side is the ability for timely feedback. So I saw an officer carrying their poster presentation earlier. You can put posters up. It's a good way to convey information. A lot of the things, and I put posters up at conferences. I'm not doing that today. And in many of the cases, we stay with those posters. So you get the information there, and then you have the person that did the research, and they can comment on it. So you get the benefit of both posted information with low feedback, as well as someone there that can respond to questions. Dynamite. Personal letters. Email, non-interactive, or even interactive email. Right in the middle area for verbal and nonverbal communication. But if you want high feedback and the ability to communicate, you're going to be doing it face-to-face on a lot of key issues, either face-to-face in groups or face-to-face one-on-one. And that, according to this slide and theory of media richness, the most rich way to communicate is one-on-one, face-to-face, individually and in groups. Okay? So, just a little thought about how do we communicate. But then, what is face-to-face? Does that mean a live webinar? And I've participated in live webinars where I'm standing up here and presenting a topic. I've got people in the room, and other people are online and emailing questions in. That's a live webinar. Does it work? Yeah. Live video class, live hybrid conference, synchronized chat rooms, in person. We're here together, and we are communicating that way. So what is face-to-face? Did anybody see all the high school kids downstairs a few minutes ago? I will tell you, I teach at one of the state universities in the state of Florida, the University of North Florida. I went in there, and one of our universities was in there. The University of Central Florida in Orlando was there. University of Central Florida, you know it, it's the second largest university in the United States, okay? Just for your information, out of the 10 largest universities in the United States, 5 of them are located in either Florida or Texas. And UCF was downstairs, and they're the second largest in the United States. At my university, only 7% of our courses are distance learning, okay? 7%. You go to a place like UCF, you can do an entire baccalaureate degree in health administration online. So they do a lot more distance learning and stuff like that. Okay. This is kind of a good quote from Mark Twain. If I had more time, I would have written you a shorter letter. Isn't that interesting? Because it's really tough to get information down and get it concise and write the short message. It's a lot easier to ramble on. I only know how to type with one finger, okay? Everybody who knows me, whether they're faculty, students, or administration at the University of North Florida, knows if I write a 2-paragraph email, that's a big issue for me, okay? Because most of my emails are short, to the point, and I don't send an email. I got an email from a student that had 9 typos in it, okay? From a student that was complaining about something, and 9 typos in something that they took time to write, the chair of the department, who has to approve their graduation. So the student comes in, he said, I'm so upset about how I'm being treated in this class and all this and that and this and that. I said, let me show you what you wrote me. And I'd highlighted, I went to William and Mary undergraduate too. So writing's important to me. And I'd highlighted all those 9 issues, the typos in it. And he says, I think I'm going to go talk to the president of the university. And I said, you know what? I said, let's look at your letter first. I said, look at the typos you had. I said, I think you and I need to get up here right now. And we need to walk over to the president's office because he needs to see this letter. He needs to see these 9 typos in the students he's bringing into this university. And at that point, the student said, I don't want to do that now. And I said, well, you need to think about how you're communicating. And I guess he's used to sending, you send 9 typos in somebody in a leadership role or within your organization. I don't know. All right. Mark Twain. Competencies. Now, we'll talk about competencies in health administration. And Nick put this slide together. We've got some very, very good competencies for healthcare leadership. It talks about the ability to communicate both in writing and verbally. It talks about basic knowledge skills in the area of finance, accounting, data analysis. It talks about critical thinking and how do you make decisions and stuff like that. All of that's real good stuff. He only showed a few of them. So what do we do in real life? Okay. You need to create a model where you set up some key variables in your organization to track whatever issue it is you're looking at. you set up key variables, and then you build metrics on those variables to track. And here's what we call those, at least in research. You build constructs. You want to look at quality, and we'll see it in a minute. You then have key variables that drive quality, and then you determine what measures, what specific outcomes are you looking at for quality. Quality, and we talked about you can do it in health, you can do it in love, you can do it in happiness, motivation, all that kind of stuff. You can create constructs. Quality, it's hard to define. What is quality? It depends on who you are, what your organization is. I will tell you how the federal government looks at healthcare quality, at least in hospitals. They use hospital compare metrics. At one time, it was a set of 32 discrete measures that measure quality. When I do research, and I don't have good access to federal hospital quality data. You guys don't participate in Hospital Compare. But Hospital Compare has 32 key discrete measurements. It deals with how rapidly you're seen in the emergency room, medications, the whole group of metrics, and then it gets into patient satisfaction, the nursing care, the physician's care, the cleanliness of the room, the noisiness of the facility. All these are metrics that the government is looking at for quality, okay? And then you look at that data, and then you measure it, and you measure it over time. So you operationalize the measures. When you're looking at age, you can look at the exact age of somebody, 79. The problem with looking at age from a research perspective is it's easier to categorize it by groups. So Nick created a categorical variable, or is it just elderly Medicare eligible, age 65 and above? So you can operationalize these measures. We talked about health. We talked about big. All right. You create your variables, outpatient care, inpatient care. Health. You measure it for an individual: blood pressure, heart rate, body mass index. So those are the key variables, and then you measure. Anybody heard of HEDIS? HEDIS was an outpatient mechanism to evaluate managed care organizations. And they would go in and they would measure how many of your people that had high blood pressure or high blood sugar were being treated for diabetes, okay? So they would measure your organization's performance against these specific measures within your patient population, okay? So those are various variables of interest, how we operationalize them, and then how we measure them by blood pressure, heart rate, that kind of stuff. Are you guys kind of getting the picture here a little bit? The measures for blood pressure, 120/80 is normal. Heart rate, 180 beats. Measures 38%, that would be obese, clearly. Cholesterol, high numbers, low numbers, blood sugar, so on. So you can measure them. And I'm not going to tell you, but you can use this process to create constructs, operationalize, and measure them in everything we're doing, as long as you have smart people that are involved and you let them participate. 61-year-old Caucasian white female presents to her primary care physician, 5'2", 250, blood pressure of 180 over 120, high blood sugar with tachycardia. That individual meets certain metrics that we know we need to provide further care for down the road. Okay. A coworker comes back from visiting a primary care clinic and says, I really like that clinic. It has high quality. What is the patient really saying? I mean, does that mean it's a new building? Does it mean the people were nice? And you have to tease out what are the right questions. If you could go back to your organization and you could use this presentation and this model to build, this was actually designed as an exercise that we could do in a group room, and we could come up with those key variables and key measures that we would want to check and track what is quality in a healthcare institution. We won't do it today. So, in summary, You can effectively communicate. You can model key healthcare issues. You know how to communicate and email, particularly on key issues where you need input from people. Email's not the way to do it. You can see how, if you build a process, it works in one set, or let's say in your organization, there are key issues. Every article I do, every research I do, looks at an issue and a topic. And the article ends with managerial implications and policy implications. If I'm going to do research, I want to have something at the end that allows practitioners, because I've been there, I've been where you guys are, that gives you a tool to move forward in what you're doing. Okay? So what are the managerial implications? What are the policy implications? And you can forward that out to other organizations. And you can have economies of scale when you develop those policies and those procedures over time. This is a little reference from a book that Nick wrote along with one of his colleagues dealing with leadership. Nick's a good friend, and many of the communication techniques and things he talked about in this book came out of Nick's textbook, Leadership and Health Professionals, Theory, Skills, and Adaptations. He's a good friend. He put the slide in. I left it. All right. I want to show you something that I found very, very interesting. And this is an article Nick and I did together in 2007. And yesterday, or on Wednesday, I presented data on measuring efficiency in federal hospitals. And I did it in 2007. And I got efficiency scores for every military hospital. I used AHA data. That you have to report, both military as well as VA. And I looked at efficiency, and we got an efficiency score for every organization, VA and DoD. And then I had access through a federal grant for JCAHO quality measures, quality scores on your facilities, okay? And I thought, let's use multiple regression to see what key factors are driving quality in your organization. And I'm going to show some, let me just show you the data. Let me flip it over. Because this question came up. I had somebody sitting right there saying, how do you know when you got the right staffing in an organization? Well, that's a good question. When you do multiple regression, you're looking at a positive coefficient under the parameter of estimate. So anything that has a plus next to it has a positive relationship to quality. And the bigger the coefficient in front, the more important and the larger magnitude it has on that quality measure. And then when you get to probability, the star means that it is statistically significant. It didn't happen by coincidence. Okay? California has a law, and it says you have to have so many RN hours per inpatient day in all the California hospitals. None of the hospitals can meet that law requirement. Okay? I looked at that in your hospitals. I looked at the number of RN hours per inpatient day because I have that data in the AHA database. I know exactly how many RNs you have. I know exactly how many inpatient days you have, and I looked at it. And the reality is, it is a positive relationship to quality. But it was not a big number on the coefficient, although it was a number, and it was not statistically significant. You got to be 0.05 or smaller to be statistically significant. How about operating expense per inpatient day? It's positive, but again, it's not statistically significant. And then I looked at the size of your organizations. And essentially very little relationship, you see 0.00. And then I looked at number of clinical services, and it had a negative in front of it, which may mean that because you're getting highly complex, you may get some lower quality scores in some of the metrics. And that I can buy that as well. But this shocked me. Up at top, the efficiency of your organizations, those best organizations for an efficiency score, look at the size of the magnitude of the coefficient and look at it statistically significant. I went through 23 years of running Navy hospitals, and when it came to quality issues, I got the doctors and the nurses, I put them all in a room, and I said, you guys figure it out, and then when you figure it out, tell me how much money you need and what we need to do and how we need to go about it. What the title of my last article was, is the quality of healthcare a function of leadership? And what that article showed me was that the decisions we make on the processes within our organizations are critical to quality. And that was an eye-opener for me. We published that. But as you go out, just think about the impact that you're going to have on quality, because it is bigger than doctors and nurses. And the efficiency, let me show you a couple others. I see a hand coming up, and we're going to get to it in just a second. There's also data to show the higher nursing turnover rate you have in an organization, the lower your quality scores will be, okay? So these relationships are important. I'll also tell you, organizations like HCA with for-profit hospitals, their bonuses are tied to quality scores, and their bonuses are also tied to nursing retention and turnover within your organization, okay? So all this stuff sticks together, and it really is important in the long run. Okay, question? No, keep in mind, the only data I have is at the hospital level. But I got to tell you, the AHA database is a huge database. It has probably 6,000 measures. Every clinical service you have in your hospital, you're reporting it to the AHA. And what we do for the size of the organization and clinical complexity is we count up all your different services. So the only data and the only thing I ever look at is the hospitals, and I group them, look at federal, that kind of stuff. All right. So here's a question, another question. How do you define quality? Good question, and I did not get a chance to define it. JCAHO did. You understand? Because I used JCAHO's reported survey data and JCAHO has specific measures that they used at the time. How do I do it today? When I do this report, when I do this kind of research on value, I'm at Piedmont Healthcare in Atlanta. I had presented data on efficiency with Tim Stack, who was the CEO of Piedmont Healthcare in Atlanta. He said, Jeff, would you come back and present this data to my board and to my leadership team? And I said, sure. So I'm presenting and talking about efficiency, and after the presentation, one of his medical directors stood up. He said, Jeff, this efficiency stuff is great, but you're only getting part of the question. And I said, please, continue. He said, Jeff, when you look at efficiency, you incorporate quality, then you're really getting into value. Value in healthcare, and that's what really matters, okay? And I'm thinking, wow, I was glad I went to Piedmont, and I talked about it because now everything I look at efficiency and I look at quality, because that is what drives quality. I'll tell you what I look at in hospitals, and that's what I look at. I look at hospital compare data. I look at patient satisfaction data. That is what I use as measures of quality. You guys come up with your own measures. I'm not going to tell you how to measure quality in your system. CMS, I think, has done a pretty good job for regular acute care hospitals, but how you measure it's your choice. How JCAHO measures it's JCAHO's choice. Okay? Good question. Okay, value. Other question, yes?
With the military hospitals, there is a big changeover in nursing, sometimes every 2 years. Did you say that was looked at too? I'm sorry.
Now, and I got to tell you, you were here Wednesday. The one lady on the right-hand corner was here Wednesday. Your hospitals, and I look at hospitals by groups. I look at for-profit hospitals, not-for-profit hospitals. I look at critical access hospitals. Woo, that's an interesting one if you know what a critical access hospital. And I look at federal hospitals. And I look at efficiency, and I can't get to quality in your line of business. I can get to quality in everybody else's. But DOD and VA hospitals are the most efficient hospitals I have ever looked at. I presented data which will be published within the next 2 months, looking at 2011 efficiency data in your business. You're 86% efficient. Your civilian colleagues can't come anywhere near getting where you are. If I had quality data in your business, I would love to add quality. I just don't have it. I know the VA is reporting it within their system somewhere. I just can't get to it. And I'm not sure I want to. I got plenty of other stuff to do. But I can tell you from an efficiency perspective, you guys have already hit the home run. If you can add the quality onto it, which I'm assuming you're doing now, you got a home run. So, what can I tell you? Harrison et al. Discussed value in healthcare services and proposed that by combining efficiency and quality and then benchmarking it, we can move forward, okay? And benchmark against the best. All of my data identifies what we call the efficiency frontier, or the best organizations. And we benchmark against the best. I'm teaching now. And I have an affinity or love for health administration. So when I am at one of 60 CAMI accredited MHA programs in the country, okay? I heard that USIS has just started an MHA program, okay? Because some of their faculty were at a meeting I presented in Chicago and came up to me. Well, you notice them in uniform, but they came up as well. When I benchmark, I only benchmark against the best health administration and programs in the country. I'm not benchmarking against mediocrity. I benchmark against the best. Okay? Let me get to something. Whenever I do a presentation, this is my slide. I want you to walk out, or at least have in here, something you can walk out and you can look at your organization and you can say, check off. Are we doing this? Are we not doing this? Are we doing this? Are we not doing this? I want you to walk away with this. Do we have a core business to build on? Absolutely. The issue you addressed about nursing and deployments in the military, your mission, your core business is so much more difficult than your civilian colleagues have to deal with. Deployments, people leaving your facility for months on end for deployments. Do we have a clear statement of mission and philosophy? Do we have a shared vision of where our organizations are going? Do we have a good business and political strategy? I don't want to get into politics today. You know what's going on at the political levels with the sequester and all that kind of stuff. Do we have a structure for responsibility and accountability? Wow. Do we have talented people? Number one asset is people, particularly in healthcare. Do we have good executives? Do we have good managers? Do we have good employees? Do we have a good medical staff? And are they supportive of what we're trying to do? I can tell you, I've been where you are. I would say you have all of that, okay? Do we have shared values within the organization? Absolutely, okay? You know, I go to Lowe's hardware store and I pull out my military ID and they give me a 10% discount with my, retiree ID. We got shared values. I still believe in those. Do we have high quality plant and equipment and technology? And I've been in a lot of your organizations and your facilities, and you do. And you should be so proud of that. Do we have sufficient capital reserves? I don't know how bad the budget is getting for you folks. I don't know how bad. Do we have a supportive community? Your patient population appreciates what you're doing. And do we look at our data, our metrics, on a 30-day basis, 60-day basis, 90-day basis? Are we looking at these key metrics? We call them a dashboard, right? The red where you got a problem, green where it's going great, and yellow where it's starting to turn, maybe not so good. Okay? Are you doing that kind of stuff? Because if you are, that's the movement for success. Summary, words are important. If you don't use them correctly, nobody will know what you mean. Okay? And I will finish off, then we've got maybe time for a couple questions. Does anybody recognize this hospital? Anybody recognize that facility? If you're in D.C., it's not too far away. Tell me what it is. What is it? It's Johns Hopkins. That building was, over the last 10 years, with the exception of this year, was ranked the #1 hospital in the country for the prior 10 years running. Okay? Let me tell you what I heard yesterday. In fact, I heard it from my wife. My wife is the director of nursing at Mayo Clinic in Jacksonville. And she said that Johns Hopkins is now admitting patients to home. And I said, what do you mean? Well, they need specific IV therapy or IV antibiotics. And they're sending somebody to the home and they're giving them. I said, I can't believe that. But Johns Hopkins is a special place too. So when you guys benchmark, look at the best. Okay? Questions? We got time for a couple questions. If not, we're going to turn the computer off. We'll turn the video and audio off, and we'll move on. Any questions? Okay. If not, thank you so much for your time. And if you want to listen to me again, you know where you can get a hold of it, from this guy. It'll be on the website.